Hi everyone, my name is Sarah Stacey. I'm the chair of the Antimicrobial Stewardship Committee at Charlotte McClay Hospital. I'm going to be introducing the Antimicrobial Stewardship program to you in a video that will explain the practical aspects of the prescription and authorization process for antimicrobials at the hospital. So since their discovery about a century ago, antimicrobial medicines, including antibiotics, antifungals, antivirals, antiparasitics, have all significantly extended the average life expectancy. And every day, these essential medicines save millions of lives. That is, until they don't. And we are fast approaching the era of civilization where antibiotics no longer have the capacity to save lives. So what is antimicrobial resistance, or AMR? AMR occurs when bacteria, viruses, fungi, and parasites no longer respond to antimicrobial medicines. And as a result, antibiotics and other antimicrobial medicines become ineffective, making infections harder and sometimes even impossible to treat. And we certainly see that happening in our own hospital at the moment. And AMR increases the risk of disease spread, increases the risk of severe illness, and increases the risk of death. And the situation is actually more critical than it appears at first glance. AMR is directly responsible for 1.3 million deaths and contributes to 5 million deaths every year, and it's estimated to cause 10 million deaths annually by 2050. And that's just the start. AMR also threatens our economic future with an estimated global annual cost of up to $3.4 trillion by 2030, which is not far away, and 28 million people pushed into poverty by 2050. The world these days is focused on developing drugs like antidepressants and statins and Ozempic, and antimicrobials have taken a backseat for a long time. This is a graph of a number of new antibiotics brought to market between 2000 and 2022. About one a year, sometimes nothing in a year, and sometimes a bumper year like 2014 where 8 antibiotics were launched. But only 7 drugs came from new classes. All the others, the bugs had seen before. The new class drug launched in 2012 was bedaquiline for TB. And the new drug classes released in 2015 and 2017 were beta-lactamase inhibitors rather than new antibiotics. Now, for those of you who are in your 20s and 30s starting your internship or your reg time, thinking either about not writing exams for a bit or just about to write exams again, this might not seem like the most important focus of your career. And even if the deaths of an extra 10 million people a year seems too esoteric to even contemplate, you might need to realize that AMR is not something that happens to other people. It is something that is happening to you and the people you love right now. And in 2050, you'll be heading towards your 50s or 60s. Maybe you'll have diabetes, maybe you need a pacemaker or you need chemotherapy. Or maybe you're still a super fit cyclist who just happens to be involved in an accident, who gets an open fracture. But for whatever reason, you end up in hospital, you get a nosocomial infection, and you die because there is no antimicrobial left to treat it. One of the ways Charlotte McClay Hospital is trying to preserve antimicrobials for this and for future generations is by promoting the rational prescription of all antimicrobials, including making sure that there is actually an indication for the antimicrobial being prescribed, ensuring the correct drug, dose, duration, route, and frequency of administration, and the restriction of broad-spectrum antimicrobials active against resistant organisms to ensure that they are only used when necessary for the correct indication. Another focus of the Antimicrobial Stewardship Program is to ensure that appropriate investigations are done in the case of suspected infection, that antimicrobials are administered without delay when needed, and that treatment is adjusted according to the results of investigations. You will become very familiar with this prescription chart. This is the antimicrobial prescription chart for CMJAH. All antimicrobials for inpatients must be prescribed on this chart. That means all antibiotics, all antifungals, all antivirals and antiretrovirals, all antiparasitic agents, whether they're intravenous or oral or even topical, whether they're stat doses or a course of antimicrobials. If it kills a bug, it goes on this chart. And if the drug does not kill a bug, it should not be written on this chart. There are a number of versions of this chart floating around the wards. This version that you see here is the current version updated in 2024. You can collect a copy of this version from my office in 552, which can be copied in the wards and distributed in your units, or you can find it in the document at the link on the slide. So how do you complete this form? Let's start with the basics. The patient's name and PMI number must be on the form. This is the basis for a legal prescription. But rather use a sticker unless there isn't one available or you can't get it printed in the ward. In addition, you must write the name of the doctor in charge of the prescription. That's generally the consultant or the unit head, but it can also be the registrar or the intern. Include the age and weight of the patient. This is particularly important when prescribing for children, but older adults and people with very high or very low BMIs might metabolize antimicrobials differently, and that may influence the dose you prescribe. Very important is recording the GFR. Patients with abnormal renal function are easily overdosed with antimicrobials, and dose adjustment is extremely important. Similarly, some antimicrobials are intrinsically nephrotoxic and should be avoided in patients who have renal dysfunction. Also, ask about and record any allergies. This is standard on any prescription chart and important to know before prescribing antimicrobials. The next step is to complete the indication for the prescription. The primary diagnosis refers to the reason for admission. If the patient is admitted with pneumonia, write down pneumonia and complete the ICD-10 code. The ICD-10 code is also a requirement for a legal prescription. You can access ICD-10 codes at the WHO site, the link is on the screen, or download an ICD-10 coding app. Also, record whether this infection was acquired in the community or in the hospital. Remember that the primary diagnosis for admission remains the same throughout the stay. If the patient was admitted with bowel obstruction remains the primary diagnosis for the duration of that admission, even if that patient subsequently develops an infection. In this example, the patient has developed nosocomial pneumonia as a complication of the admission. So the reason for the prescription of the antimicrobial is pneumonia, but the primary diagnosis remains bowel obstruction. Record whether the investigations have been sent before or after the patient has received antimicrobials. Always remember to send appropriate investigations before prescribing the antimicrobial. Doing the investigations after the antimicrobial has been given reduces the yield of the sample sent, which may happen even if the antimicrobial used isn't targeted against the organism. And so you may not have any useful microbiological results to guide your treatment going forward. Sometimes the patient may be receiving a second course of antibiotics for a new infection. Then you would record that the investigations were sent after the antibiotic was given. It's very unusual not to send a sample at all, and there should be a very good reason for not doing so. Then you need to prescribe the antibiotic. Choose an antibiotic that is appropriate for the indication. Some of the things to consider are: does the drug need to cover community or hospital-type organisms? Does the drug need to be active in a particular compartment like the brain, blood, soft tissue, abdomen, or somewhere else? Can the drug be used in the age group you're prescribing for? How bioavailable is the drug, and can it be given orally rather than IV? Is there a microbiological result? And have you chosen the antimicrobial with the narrowest spectrum that can be targeted against the organism? Using a broad spectrum antimicrobial when a narrow spectrum agent will work is not appropriate. The prescription must include the name of the drug. Both the trade name and the generic name are acceptable. The dose must always be double-checked, especially to make sure that the dose is correct for age, weight, and renal function, as well as to make sure that the dose you have chosen is correct for the compartment you're aiming at. For example, Rocephin or ceftriaxone needs a higher dose to be effective in the CSF compared to in the blood. No one can keep all the doses and dose adjustments of all antimicrobials in their heads, and it's dangerous to assume that you always know the right dose. You must include the route of administration and the frequency. Record the start date and time. The time is important because delayed administration of an antimicrobial can have dire consequences. And if the time is not recorded, it's not possible to know if it was prescribed at 8 in the morning or 11 at night, when the patient only received the antibiotic at 11 o'clock at night. And then the prescription must be signed properly. This means that all parts of the script must be completed and completed legibly. Prescriber's name, qualification, registration number, contact number, and a signature. The contact number must be the personal number for the prescriber, not the number of the ward. The reason for this is to ensure that the nursing staff or the pharmacy, if they have a query about the script, the doctor must be contactable directly. If a query can't be resolved, the patient may not receive the antimicrobial they need. Indicate whether the antimicrobial is empiric. In other words, there are no microbiological results available yet, or definitive. In other words, the drug choice is targeted against an organism found on an investigation. Any empiric prescription will be authorized for 3 days only, and the pharmacy will only issue antimicrobials for 3 days. After 3 days, further information will be required for additional authorization or issue. No antimicrobials will be issued or authorized for more than 7 days at a time. There are only 3 spaces for antimicrobials on this chart. It's unusual for a patient to need more than 3 antimicrobials at a time. Obvious exceptions include patients who are receiving antiretrovirals as well, or drug-resistant TB therapy, or who have multiple nosocomial infections. It is important to review the prescription of any antimicrobial on day 3, day 5, and day 7 to ensure that the patient still needs the antimicrobial, that the antimicrobial you prescribed is still the right one, and that there are no side effects from the antimicrobial that mean you should change the script. The reverse of the chart, which should also have the patient's name and PMI number on it, contains spaces for stat doses of antimicrobials, which includes loading doses. In the same way that you need to check doses and frequencies for recurring doses, it's important to check if the antimicrobial you're prescribing should have a loading dose as well. At the bottom of the page is a space for recording the microbiology results. If multiple results are available, remember to record them all. It also helps to have this information at your fingertips when you're asking for authorization for antimicrobials, and the authorizer needs to be convinced that the antimicrobial is necessary. Right, so what's the process for authorization of antibiotics? Firstly, not all antimicrobials require authorization. It will be a waste of your time and the authorizer's time to look for authorization for a drug that doesn't need authorization. But if a drug does need authorization and you don't get it, pharmacy will not issue the drug. Only consultants on the list can authorize antimicrobials. No registrars or fellows can sign, and not all consultants can sign either. Check the list to know who is allowed to authorize antimicrobials. Also be aware that some antimicrobials, in particular colistin and penicillin, need a Section 21 form filled in. In the case of these 2 antibiotics, we have bulk Section 21 permissions, but the patients still need to sign consent to receive the unregistered medication. There are other antimicrobials that need Section 21 permission, and pharmacy may ask for these. Consent forms for patients are available at pharmacy, but Section 21 applications should be done online. This is the current list of antimicrobials that require authorization from a recognized authorizer. Some of these drugs require additional permissions. Colistin, tigecycline, ceftazidime avibactam, and ganciclovir, as well as its oral equivalent valganciclovir and voriconazole, require a signature from the AMS committee member or microbiologist. Some of these agents also require authorization from the head of the PTC, the Pharmacy and Therapeutics Committee, who is Prof. Paget at the moment, because these agents are expensive and last line of defense agents. This is the current list of authorizers. As you can see, there are more authorizers in certain disciplines. Attendance at an antimicrobial stewardship course is required to get onto the list, and certain departments have been more conscientious about sending representatives to the course. Firstly, try to get authorization from consultants in your own departments. Apart from anything else, they know more about the patients and the conditions being treated, and so it's generally quicker. This applies in particular to pediatrics. Small people are very different from big people, and that difference needs to be considered when prescribing antimicrobials. And so authorization for peds is best obtained from pediatricians. Similarly, authorization for adults should be obtained from departments other than peds. Secondly, it is very, very important to get authorization early in the day. Antimicrobials prescribed on morning rounds should be authorized, issued, and administered in the morning. There is very clear evidence that delays in administering antimicrobials mean poor outcomes. In other words, people die if they don't get their antibiotics on time. Authorization should be obtained in person. Rarely it is acceptable to get telephonic authorization. Now we know that there are some times when an antimicrobial might be prescribed later in the day. If someone comes out of theatre and needs a new antibiotic, if new results become available, or if someone presents to hospital in the afternoon, for example. For this reason, we have a roster of consultants who are available to authorize the antibiotics in the afternoon. This roster is only for between 2 and 4 p.m. on weekdays and between 7 a.m. and 4 p.m. on weekends and public holidays. Before 2 p.m., you should be obtaining authorization from your own departments. After 4 p.m., for urgent cases, authorization is not required. Antimicrobials can be accessed from the emergency cupboard in 286 or from the pharmacist on call, but you will only receive enough doses to cover the nighttime doses. Authorization must be obtained the following morning. The roster is also available in the Google document. So lastly, CMJAH management expects all employees to exhibit a high level of professionalism and ethical behavior. You must be aware that forging signatures and falsifying telephonic consent is fraud. If you use the name of a consultant in any way on a prescription, which is a legal document, without that consultant's permission, you have committed fraud and will be held accountable. This is your first warning. An internal hospital disciplinary procedure will follow any transgression, but the consultant whose name you have used illegally can also institute independent legal proceedings against you if they choose to. If you have received one written warning for the first transgression, the second transgression will be reported to the HPCSA. This is the written warning that you will receive if you forge a signature or telephonic authorization. A copy of this written warning is also available on the Google document. Thank you for your attention. Antimicrobial resistance is invisible, but its victims are not. And the goal of the CMJAH AMS program and programs like this around the world is to ensure that we, our friends, our families, and our patients don't become victims of AMR.